Good afternoon, everyone. Today I'm going to take class on epilepsy. Majorly, I'll be covering treatment part of the epilepsy. So, first thing is, what is epilepsy? Sorry? Okay, multiple episodes of seizures. So, now the question is, what is seizure? Seizure. You know that epilepsy is multiple episodes of seizures. So, what is seizures? Abnormal? Okay. So it's a abnormal electrical activity. It's abnormal electrical activity. You know that it is abnormal electrical activity due to which what happens? Okay. Okay. So there will be due to which there will be abnormal sensory experience. See, seizures, it might not be just of the jerking movements. It can be about the memory or the sense. They might not feel anything. The taste buds might not work, or that they can't see. That can be different. That is abnormal sensory experience. Another thing is abnormal motor experience. So basically, we know regarding this, right? Motor experience. We usually see this kind of cases more. So you might have the jerking movements or atonic. That is, there might not be any power in the body. That are the things which are the abnormal motor experience. The other one is abnormal psychomotor experience. Okay, this is again regarding the psychology things. Okay, psychology of the brain. So this is the proper definition of seizure. That is an abnormal electrical activity which leads to the abnormal sensory experience, abnormal motor experience, and abnormal psychomotor experience. This is seizure. So now the set of the few episodes of seizures together are called epilepsy. Okay. So now what are the types of epilepsy? We'll talk about the types of epilepsy. Okay. What are the types? Partial seizure. Okay. What are the main two types? I'll say there are two types mainly. Generalized and partial seizure. Okay. So basically now the term partial seizure is not used. In place of partial seizure, they use focal seizure. That is a new terminology which are used. But for the purpose of saying, I will use partial seizure itself. So there is partial seizure. Okay. So it can be called as focal as well. So there are two types of partial seizure. What are they? Simple partial and complex partial. Simple and complex. The difference is loss of consciousness. Simple partial, there will be no loss of consciousness. Complex partial seizure, there will be loss of consciousness. These are the difference. The another thing is this partial seizure can turn into generalized seizure. Okay, so I'll explain about partial seizure. So if you consider this as a brain, okay, consider. So the partial seizure is there will be abnormal electrical activity in just one place. Okay, one place, due to which there will be only the specific. If it is in the right side of the brain where the motor neurons are there, then there will be an issue with the left hand. Okay, that's how it is. Just a one part of the body. That is partial seizure. So when there is a loss of consciousness due to it, then that is complex partial. If there is no loss of consciousness, there is simple partial. When this focal, that will start by here Abnormal discharge will start by here, but it will spread throughout the cortex. That is generalized. Okay, so this type is generalized seizure, secondary partial seizure, secondarily generalized seizure. Partial seizure, which will be secondarily generalized. So it becomes generalized seizure. That is the another thing. The other thing is generalized seizure, as you guys know about it. In this case, in the beginning itself, the abnormal discharge will be throughout the cortex of the brain. Okay, that is how the generalized seizure is there. So in this generalized seizure, there are another few different types of generalized seizure. What are they? Anyone knows? Yeah, tonic clonic, atonic, myoclonic, and absent seizure. These are the different types of generalized seizure. Tonic, I'll come to the tonic first. In tonic, there will be stiffness of the body. Due to the abnormal discharge, there will be just a stiffness of the body. That is tonic. In case of clonic, there will be like voluntarily jerking actually. The abnormal discharge is like alternative. Once it will be there, once it will be not there. That is why there will be jerking movement in case of clonic. Okay. In case of atonic, tonic clonic, first there will be a stiffness, which will convert to the jerking, then again stiffness, and then again jerking. That is how tonic clonic is. Okay. Now coming to atonic. Atonic is an opposite to tonic. That means in tonic there will be a very stiffness of the body is present, but in case of tonic there will be no strength in the body. They will become like a mask, a ball. They'll fall off and they'll collapse. That is how the atonic is. Myoclonic is it's again the type of clonic, that means the jerking movement, but it is involuntary. Suddenly, if the patient is trying and he has a plate in his hand, so when the myoclonic starts, suddenly he will throw off his plate or something, and it will be very involuntary. The jerking movement will be very involuntary. That is myoclonic. Okay, these are the types. Okay, the other one is absent seizure. What is absent seizure? In that, there will be no jerking movement, there will be no stiffness, there will be no loss of any power of the body. The person will be keep staring at one place, and he will be standing or be sitting, whatever position he is in. Okay, that's how it is. And absent seizure is mainly seen in children's. So usually it's very difficult to diagnose. If a kid is in college, school, and he will be listening to class, he will just blank out for a moment, and teachers or students, they will not come to know that whether what is happening to him. Okay, then another thing is simple partial, which is secondarily generalized. What happens is the patient might be talking abnormally for a moment, because that particular the location of the brain is discharging the electrical activity discharges abnormal, because of which she or he might be abnormally speaking. That will, after a few seconds, it will go to turn into this tonic or atonic or tonic clonic or myoclonic. That is how you see a partial, which is secondarily generalized to it will secondarily become generalized seizure. That is how it is. These are the types of epilepsy. Hope everyone are clear about it. Okay. Now we know the types. We know what is seizure. We know what is epilepsy. We will get into the drugs, the treatment part. Before going to the treatment, I want to say about the drugs which act on this, the mechanism of action. Generally, I want to say. So what exactly happens is, okay, consider these are the synaptic nerves present in the body. This is glutamatergic neuron. so which will release glutamate. This is GABAergic, which will release GABA, and these are the what do you call the nerves, neuron present in the body. Okay, so in the normal discharge, what will happen? There will be proper release of glutamate, there will be proper release of required amount of GABA, and required amount of action potential, due to which proper normal conduction of the nerve is present. But in case of epilepsy, the abnormal discharge activity, there will be increased amount of glutamate release, or there will be a decreased amount of GABA release. That is that will cause the increased action potential, abnormal action potential, and due to which there will be seizure. So how this so if you know the mechanism here, you can relate the drugs which act on the anti-epileptic drugs you can relate. Okay, so how exactly the glutamate is released is, there will be a receptor which sodium voltage gated sodium channel. There will be voltage gated sodium channel, which in which the sodium enters the neuron, due to which there will be depolarization. Okay, and here there is another receptor, there is a channel which is called voltage gated calcium channel. Okay, this is voltage gated calcium channel, due to which the voltage this calcium will enter into the neuron. First sodium will enter, due to which there will be depolarization, due to which the calcium will enter the neuron. There will be vesicles. These are the vesicles which contains glutamate. Okay, this has a receptor where the calcium will bind, due to which this glutamate vesicles will bind to the synapse, due to which there will be a release of glutamate into the synaptic space. Okay, this glutamate which released will enter the normal neuron. This increased glutamate will increase the entry of sodium channel, sodium into the normal neuron, and calcium into the normal neuron, which will increase the action potential. This is normal mechanism. When there is an increased glutamate, there will be increased sodium and calcium impulse into the neurons, and due to which there will be abnormal action potential, due to which there will be abnormal nerve conduction, and due to which there will be seizure. This is how it is. This happens when there is increased amount of glutamate release. That is one thing. These receptors are called as AMPA and NMDA. Okay, this is one thing. Another thing is GABA. The neuron, when there is a decreased amount of GABA, there will be increased action potential, and there will be seizure. Okay, here what happens, there is a vesicles which has GABA. So there will be entry of sodium. Okay, this doesn't have sodium thing. There will be normal action potential, which will make the vesicles bind to the synapse. Thus the GABA is released, and this GABA via GABA A receptor enters into this GABA will make chloride enter into this, and they will balance the action of glutamate, right? So this is how it is. When there is a repolarization, again the decreased there will be decreased action potential, and thereby decreased that is a normal condition. When there is decreased GABA levels, there will be entry of chlorine into this normal nerve is decreased, due to which the action potential is not reduced, so it will go up, the abnormal action potential, due to which there will be seizure. This is the normal mechanism. This GABA, the excess GABA which are present, will be re-entered into the nerve by GABA reuptake receptors. From here the GABA re-enters into the neurons. This GABA is can be reutilized, and then again the same action will be there. Or else this GABA which enters gets converted, they will get metabolized into metabolized form in the presence of enzyme GABA transaminase. Okay, transaminase. This is the normal mechanism. When this thing are not working properly, there will be decreased GABA, due to which there will be abnormal action potential, and due to which there will be seizure. This is the normal mechanism. When there is abnormality, like there will be increased glutamate levels, or there will be decreased GABA levels, so this point of time the drugs, anti-epileptic drugs, will act on this place. Okay, that is how it is made. See, we have sodium, voltage gated sodium channel blocker. Okay, one thing, and there is another thing is calcium channel blocker is there, another thing, and another thing is this vessels are called as SV2A. Okay, this receptors, that is synaptic vesicle glycoprotein 2A, the blocker of this, another thing. Okay, due to which the calcium will not bind to it, the vesicles are not binding to the synaptic walls, and the glutamate is not released. That is the another position where the drug can act. Other thing is it can act on this receptor, and another one is this receptor. Okay, and these are the drugs which act on the glutamate activity. Okay, other positions where drug can act and stop. Now the GABA, we can increase the levels of GABA, so thereby we can stop the seizure. These are GABA reuptake receptor blockers, then GABA transaminase enzyme blockers, inhibitors, then this GABA uptake, they are called GABA A receptors, the GABA A receptor blockers. Okay, these are the positions where drugs can act. So basically we have 1, 2, 3, 4, 5, 6, 7, 8 types of drugs, the class of the class. So sodium channel blockers, can anyone say the example of it? Sodium valproate, yeah, one thing. Okay, lamotrigine. Okay, yeah, one important drug, carbamazepine, and there's one brother of carbamazepine, oxcarbazepine. Okay, what are the other drugs? Phenytoin. Still so many are there. Phenytoin's brother is there. No, phenobarbital doesn't come. First phenytoin. Then topiramate. Anything else? Huh? Levetiracetam won't come in sodium channel blockers. Okay, so now we are done with the sodium channel blockers. There is calcium channel blockers. Any example which you know? There is a drug called ethosuximide. I think pediatrics, whoever has gone might have seen this drug. Have you? Okay. So these are usually used in, this is the first line therapy for absence seizure, and kids or the children are more prone to absence seizure, and these are mainly used in that case. Okay. Then there is SV2A blockers. A very famous and favorite drug, levetiracetam. Spelling is right? Okay. So you know sodium channel blockers now, you know sodium calcium channel blocker, you know SV2A blockers, AMPA and NMDA blockers. NMDA blockers are ketamine, AMPA felbamate. Felbinamate or felbamate? Felbamate. Okay. So see, these drugs will decrease the glutamate levels and thereby decrease the action potential, thereby there will be no seizure. That is how it is. Now coming to the drugs which act on the GABA neurons. So this thing, GABA reuptake inhibitors. Diazepam, GABA reuptake inhibitors. Benzodiazepine, then barbiturates will come as a GABA A receptor inhibitors or blockers. Okay, agonist. I'm sorry. So this is agonist. I'm really sorry. This is agonist. Okay, GABA receptor agonist. Examples come again. Benzodiazepines. What drugs which are used in benzodiazepine? Diazepam, lorazepam, clonazepam, clobazam, and midazolam. Okay. And barbiturates, again phenobarbital, pentobarbital, and so on. Okay. Then again propofol and topiramate also comes. So you might have seen this topiramate previous as well. Okay. So topiramate is the drug which has both activity in the GABA, which is decreases the GABA activity and also decreases the glutamate. Increases the GABA activity and decreases the glutamate activity. One thing. Then the other drug which act is GABA transaminase inhibitors. That is this thing, GABA transaminase inhibitors. Here also one famous drug comes, that is sodium valproate. Okay. Another is vigabatrin. So these are the drugs which inhibits the GABA transaminase. Another is GABA reuptake inhibitors. That is one drug is there which are not majorly used. Tiagabine. These are the total anti-epileptic drugs which are used. I might not have covered a few of them, but these are the major drugs used. Out of this. This is vaccine. Okay. Sodium valproate is used mainly. Carbamazepine is mainly used. Ethosuximide in case of absence seizure used. Now presently levetiracetam is widely used. And in case of status epilepticus, we use benzodiazepine. So I'll be telling about this. Okay. So in case of partial seizures, carbamazepine, in case of partial seizure, carbamazepine and levetiracetam, then oxcarbazepine are used. Mainly carbamazepine and the levetiracetam are the drug of choice in case of partial seizure. Even lamotrigine can be used in case of partial seizure. And in case of partial seizure, which will convert which becomes a generalized seizure, in that case also we can use carbamazepine. Okay, not written. Carbamazepine we can use. This is again a first choice drug in that case. In case of absent seizure, ethosuximide is the first choice. Then comes sodium valproate. Again, sodium valproate can be used in case of absent seizure. And the other drugs for generalized seizures are mainly used are carbamazepine is not used for generalized seizure. One thing you have to note. Sodium valproate is mainly used in case of generalized seizure. The other drug of choice is levetiracetam. Okay, levetiracetam are the other drug of choice. Then one more thing is that there are some other type of epilepsy which won't fall under any of this. So they are called West syndrome or Lennox-Gastaut syndrome and all. They are the different thing. For them, the drug of choice is again different. So these are regarding the drugs which are used. Now coming to the dosing thing. Okay. So usually how we will treat seizure. So for example, a patient comes, he will have one episode of seizure and he will come to you. What you will do? Huh? What will be the, okay? For example, it's a generalized tonic-clonic seizure. What you will do? Sorry, what will be the drug of choice? There will be no any past history of seizures. He will come with just a tonic-clonic seizure to you. It's a first episode which is in. He has come to you. What will be the drug of choice? The thing is, when the patient comes with one episode of seizure, you shouldn't treat him with any drugs. You should wait for the other, if you wait for the second episode. Only if the second episode comes, then you have to start the anti-epileptic drugs, okay? And one more thing is, if you see a patient, is having a seizure right now, so what is the thing which you have to do at that point of thing? First aid. Huh? You'll give some key or something? No, you should never supposed to give any key or something because it will harm him. One more thing is you have to keep him in the sideway position where you should remove any of the things which are present in his mouth. So because during seizure there is a chance of aspiration. That is the first thing you have to do, okay? So this is thing. For example, now he came with the second episode. That time you have to start with a drug, okay? See, now the second time you're giving him a drug. So after some time, after a few months, he might come with third episode. That time, or there will be an ADR of, for example, you're giving him carbamazepine. You might have seen Steven Johnson syndrome in that patient. That time you have to change that drug, obviously. That case, and so if the patient comes in that way, you have to change the drug. Or else if after giving carbamazepine or after giving any anti-epileptic drug and if he comes with another episodes of seizure, you have to either increase the dose of the carbamazepine up to the tolerated dose, or else you can add another drug and slowly taper carbamazepine. That is one thing you have to note. You can't abruptly stop any anti-epileptic because when you stop abruptly, it will cause seizure again. Okay, that is one thing. Another thing is, again, if after the second episode you are giving him a new drug, and again if he comes with the second episode, third episode, then you can either give the third new drug and taper the other drug, or you can start with the two drugs, okay? One thing is the research says that monotherapy is better than polytherapy. That is why we start with monotherapy. Later on we shift to the polytherapy, okay? Even after that, if the patient's seizure is not reduced, if there is an episode, then we go to other surgical things or vagus nerve stimulation are the other choice in the final stage. This is briefly about the treatment. Now I'll come to the dosing, okay? So I think you people are sleepy. Okay, so the carbamazepine, this is one important drug which we use. The main usual dose which we give is 200 mg per day. Okay, in case of children it is 100 mg per day. It can be given up to 1.2 grams per day. One special thing about CBZ is it is a inducer, hepatic enzyme inducer. So what CBZ do is after 1 to 2 months, it itself induces its metabolism. That point of time you have to increase the dose, okay, up to 200 mg. Okay, the 400 mg almost, I guess. I'm not sure about this, but the tolerated dose or the maximum dose will be 2 grams per day at that point of time. It is usually 1 to 2 months after the initiation of the therapy. That is one thing you have to note about carbamazepine. Okay, so this is about carbamazepine. Then comes about sodium valproate. The normal dose is it is sodium valproate 10 to 15 mg per kg. Okay, it will usually come till around 500 mg per day, so we can give like 250 mg BD. This is about sodium valproate. The other drugs which we give are phenytoin. Phenytoin, in case of phenytoin, it is 100 mg per day. But one thing about phenytoin is few people they prefer giving loading dose. Again, it depends upon the physician choice. So if you're giving a phenytoin loading dose, it will be 1 gram divided in 3 doses. Okay, this is about phenytoin. This is the major. Another levetiracetam. You might know about levetiracetam. Dose 500 mg. 500 mg BD. This is the initial dose of the levetiracetam. The maximum dose is 3 grams per day. Okay, these are some important thing. Anything else? Again, lamotrigine, if you are giving this is metabolized in liver, so you have to make sure of enzyme inducer and enzyme inhibitors, enzyme inhibitors. So when you're giving lamotrigine with the valproate, or when you're giving with lamotrigine with the carbamazepine, the dose adjustment has to be done of this lamotrigine. Again, sodium valproate is the enzyme inhibitors. So this will increase the level of lamotrigine or decrease the level of lamotrigine. Okay, so you have to make sure of that things. These are about the drugs. Now coming to the ADRs, which are mainly seen. One thing which we specially note is Stevens-Johnson syndrome. Okay, the drugs which cause Stevens-Johnson syndrome are CBZ, carbamazepine, ethosuximide, and lamotrigine. These are the drugs which can cause the Stevens-Johnson syndrome. Then coming to teratogenicity, that is you should be careful while giving in pregnancy. The drugs which shouldn't be given in teratogenicity. Shouldn't be given, which has a teratogenicity. Valproate, phenytoin. Anything else? Carbamazepine. These are the drugs which we have to be careful in case of pregnancy. The other thing is hepatotoxicity. CBZ again. Another is lamotrigine. Okay, these are the drugs which can cause hepatotoxicity. I think I've covered most of the things. Again, valproate can cause pancreatitis. Okay, that is another thing. Then carbamazepine. which can cause a decrease in depletion of sodium levels. Then another important area of phenytoin is gingival hyperplasia. You can see a more the hyperplasic thing in the upper part of the teeth. That is one thing. These are main areas. I think I covered most of the things. Yeah, thank you.